Well, it was a lot more fun when I was with you in Chicago. I'm sorry I couldn't be with you this time, but I'm glad I have the opportunity to speak to you. And what I really would like to talk about is the highs and lows of pot as medicine. You know, when we talked last year, this was everybody's common perception of the marijuana user. But as you can see, times change. There are now more than 5 million registered medical cannabis cardholders in the United States. That's a significant growth. Actually, only 6 states make both medical and adult use marijuana illegal. The rest of the states allow either medical or recreational or both. I don't know of any state that allows just recreational. They allow it a minimum medicinal and then allow recreational in some states. The states that are marked in red do not allow either. We anticipate that almost $40 billion will be spent in legal marijuana this year, and more than a quarter of that was actually spent on medical marijuana in 2022. People are using marijuana and they're using it medically. And one of the reasons we at Syria are speaking out, particularly the professionals, is to get them more involved in marijuana because their patients certainly are. There have been significant changes as well on the research front, which has included a very watershed moment in American cannabis when the National Academies of Sciences, Engineering, and Medicine, a highly credible research group, published a report on what we know about medicinal marijuana. Although early research, it called for serious research regarding medicinal marijuana at the federal level. What they found was that there was clear use of medical marijuana centered around nausea and vomiting, especially in oncology, chronic pain, and spasticity. I want to go back there for a minute to the nausea and vomiting. One of the best predictors of longevity of a cancer patient is their ability to remain on chemo, and the ability to limit nausea and vomiting is seen as a very important strategy there. They did find some problems, but they didn't identify them as very significant. Its use is problematic in pregnancy, those operating machinery, especially driving, or using heavy equipment, and chronic adolescent use due to its impact on academic achievement. So these are significant changes at the federal level, but the most significant change is actually on the regulatory front. For the first time since the law on drugs, the federal government has been proposing regulatory change. When we spoke last year, marijuana was considered a Schedule I drug, up there with heroin, LSD, PCP, ecstasy. These drugs are perceived to have a high potential for abuse. There's no known medical use for treatment. They have recommended now, and it's in the process of regulatory change, that it be Scheduled III. That's a big change. It skipped Schedule II. This has accepted medical use with less potential for abuse. So hydrocodone, anabolic steroids are in this category. It skipped Schedule II, where morphine, oxycodone, methamphetamine is. So this rescheduling of marijuana is very significant. Not only does it make marijuana legal when used medicinally, and that's the important part, when used medicinally, but if they follow traditional pattern of Schedule III drugs, it requires a prescription. And that means eventually that prescribers, physicians, will be involved. So with the medical use of marijuana in mind, let's examine the various marijuana delivery systems. And there are basically four groups. The first one is smoking, probably the best known, probably the least used medicinally. But smoking is the joint, the pipes, the bongs that you've probably heard about. The next use is vaporizers. Vaporizers are a smokeless method which they extract the marijuana by heating the marijuana and it's inhaled as a vapor. There's been a lot of experimentation with that, particularly through vape pens, which of course there are significant problems. The third is through edibles, infusing the cannabis into food or drink, allowing the patient to avoid any inhalation. Edibles offer long-term relief. They take longer to activate. Concentrates, these are tinctures. They're drops, isolated masses extracted with a solvent. And it has the cannabinoids and terpenes in it. And it can be used as drops for medication. Of course, the last had tinctures where it's in a thinning agent of some kind, such as a lotion or oil, and it's absorbed through the skin. Probably the most important aspect of this is understanding the variation in onset and duration. Inhalation onset is instantly to 30 minutes. The duration is 90 minutes to 4 hours, depending on the strength. So it's pretty immediate, especially in the instantly aspect of that. Ingestion takes a little longer. Onset 45 minutes to 2 hours, and the duration can last from 4 to 8 hours. And this is where we're seeing a lot of overdoses because overdoses, not the medical overdose that you see with heroin or morphine. It's the overdose where somebody gets very high, gets scared usually. The usual presentation is fear. And the reason is that they have seen their friends inhale marijuana and get an immediate reaction. So they take a gummy, let's say, and nothing happens. So they take another and nothing happens. And they take another. And pretty soon they have a pretty good concentration of THC in their body. And it can last for a long time. So these are folks that you read about in Colorado, California, that end up in emergency rooms. And the topical is instantly to 30 minutes, a duration of 2 to 6 hours. So let's take a minute and take a look at patients and what are patients doing with marijuana? Well, in recent research, we saw that a not inconsequential number of patients have described replacing some or all of their prescriptions with marijuana. And you can see from this slide, there is folks replacing some of their prescriptions and even significant numbers replacing all. Of course, one of the problems with this is if they completely replace medication with marijuana, they're not getting the effect of the medication that was prescribed. This is another argument that we're making at Chiari, that physicians and prescribers need to be engaged in a patient's marijuana use so that they can advise the patient on the proper way to proceed. You can see from this that it's used in a variety of conditions and that patients appear to be satisfied with it. Why do they choose marijuana? Well, New Frontier data asked patients why they chose marijuana. 51% wanted a more natural treatment option. 48% wanted to reduce or eliminate prescription drugs. And this was especially true for pain medication which had a sedating effect. 29% were using cannabis as an alternative to pharmaceuticals they felt were not working for them. And 96% were using medical cannabis to reduce their use of prescription medications and feel that they had been successful. So this is a significant aspect of patient use of marijuana and a significant reasons for why they are using it so regularly. Now, frankly, all of them like to control. Cannabis provided them treat their condition more episodically. They could use it when they needed it. They didn't have to use it if they didn't need it. If they woke up without pain, they didn't have to wait for it to come on board to affect the pain that they were feeling, the spasm, etc. Frankly, however, marijuana is not benign, and there's some legitimate concerns with its use. One of the problems that we see with physicians not being engaged as much with marijuana is that these concerns get pushed aside when patients go to the dispensary and talk to the people there about their use of marijuana and don't get the effect of medical advice in its proper use. One of the early problems with marijuana was the inability to do research because it was categorized as a Schedule I substance. Doing research, unless you did it federally, which was very complicated, there wasn't much specific research on marijuana. And indeed, most of the research was being done overseas, in particular in Israel. Also, when you take medication that is prescribed for you, it's consistent. If you buy it at Costco, if you buy it at CVS, if you buy it at Walgreens, you're going to get the same medication because it's controlled. The interdispensary inconsistency is significant in marijuana. So you're not getting consistent marijuana, consistent medication. One of the things we're also seeing is significant escalation of THC. THC, or tetrahydrocannabinol, is one of the active ingredients in marijuana, and it is the substance that gets you high, gives you the effect of feeling high. As a result, people can take it and continue to get that high feeling. We're seeing, when I started in marijuana, we were at maybe the high dose of THC was 16 to 18%. We're seeing THC levels now, particularly in some tinctures, of up to 90, 92% THC in tinctures. So there's an escalation of THC, and that has its own set of problems. Of course, any physician who prescribes wants a standard dose. He wants to know that there's X number of milligrams in whatever he's prescribing, so that when the patient calls and says that isn't working, he can make a judgment and want to increase it X amount and know that there's a standard predictable dosage. Marijuana has been very resistant to being able to do that, trying to find a standardized, significant dosage that is predictable, especially back to the earlier point with the interdispensary inconsistency in marijuana. Of course, the report I showed you earlier talked about cannabis use disorder, especially in young people, that it got to be abused as alcohol is in that age group. And it can cause some real significant problems, resulting in requirements for professional intervention. And of course, doctors don't like to prescribe something you smoke. And if you inhale marijuana in the vaporizers that are on the market right now, there is very, very little standardization of the dosage that you're receiving when you inhale. Although that is the preferred use because it's so fast. Given all of this, the vast majority of physicians are not informed about medicinal marijuana, do not have a background in marijuana as medication, and most significantly, are unwilling to discuss medicinal marijuana with their patients except to dissuade them from its use. This is becoming a serious problem as more patients use marijuana medicinally, since in the absence of their doctor's willingness to discuss marijuana, patients will seek advice elsewhere or self-medicate. And certainly the web is full of opportunities to do that. And there are bud tenders that will give you advice on your particular medical condition. I'm very pleased to see the move to Schedule 3 for marijuana so that we can start to get some medicinal intervention with the medication for patients who are using it. There are some strategies to discuss with patients that work in dealing with marijuana. The first is to partner up. Don't do marijuana alone, so that there's somebody with you if it doesn't go the way you want it to, if you get scared. Go slow, be patient. This is especially important for edibles that I mentioned earlier, because it's very easy to overdose on those because you think you're getting no effect. So go slow. Go low. People will go into a dispensary and ask for high THC content because their buddy told them that's what they want. That isn't what they want. They want low levels of THC, low concentrations of marijuana to see if it has the effect that it's desired medicinally. This next one is important. Involve your doctor and other professionals involved in your care. And this is why we're out speaking to professionals to say, become involved in marijuana so you can advise your patient realistically. Having doctors involved in the care also takes into account the other medication that may have been prescribed for your condition, which is also very important. Keep a log or a journal telling what was taken, the exact time or day it was used, why, what its effects were, and what its impact was. That journal is what allows us to understand the effects of marijuana on your particular condition. The problem is we don't have the research yet that is blind that would allow us to actually predict that. The journal is the only method we have to gather that information. And hopefully you'll see results with researchers and patient support groups. We at Chiari just got done a significant study in Parkinson's, looking at the effect of marijuana in Parkinsonian dyskinesia. We also just completed a research study, early research on the use of marijuana in late onset Alzheimer's disease, or LOAD. This is a study being done with the folks at Drexel University Medical School. Early results seem to indicate a correlation. We're now looking closer to see if it's a predictable relationship. Even if healthcare professionals disagree with marijuana's medical use, we believe they should take steps to be informed. And to be helpful to their patients, they need to update their own education in marijuana, keep an open mind, gather information from their patient, validate their symptoms, which I assume they would do anyway, validate their feelings, listen, then reflect, then advise. What happens often, I've done a bunch of grand rounds, various hospitals where some physicians in the audience say, I'm just telling my patients no. What happens is the patient just walks out and finds another source. And that's not good care either. There have, however, been some recent innovations to improve safe access. A company called Mode created a device that allows for predictable dosing. Those capsules you see here, if I can get them, these capsules have measured dose of marijuana, and when placed into the Mode device, give a predictable dosage that is inhaled. Second is an inhaler. Again, it gives a measured dose, but this is more inhaler on the speed of like an albuterol inhaler. Measured dose when you take a puff, certain amount of medication going into the patient. And the third, I'm especially excited about, is really a patient portal through a company called Tetragram, which allows for the journaling I told you, which is so important. They're building relationships with dispensaries to get very specific information, as you can see here, so that professionals can get an understanding of what's going on with the patient as they go through the marijuana experience. And last but not least is a company that was started by two doctors at Harvard, Steve Korn and Meredith Korn. They are married. They're both anesthesiologists. And they started a company called The Answer Page. And it was started as a factual resource regarding medical marijuana. Their programs are medically based. They've been improved in most states to provide professional education for where licensure for medical cards is required. And these are just some examples of the data that they've provided. I'll call your attention to the one in the center, the perioperative considerations. We have gone on their website and downloaded this particular paper and suggest that patients download it from our website and take it with them if they're going to undergo conscious sedation or any type of anesthesia because of its implications. That's a very good study. You can get it on their website. They also provide a free daily email. That's where they got their name, The Answer Page. With a question every day. It comes with a question about cannabis and an answer. And I think you can see from the answer, they're based on random trials. They're very reasonable. We were very impressed with what The Answer Page has been able to do. We did speak to them before this conference to see if they could provide CME, and they do. The dose of cannabis education I showed you is free, and they allow a discount, a CME, the accredited courses. There's approved throughout the country for approved CME, and suggests that the ASAP code be used when you sign up. If you take a picture of that QR code, that will take you to your website. And even if you don't want to take the CME, you get a lot of information there that's very scientifically based and appropriate.